Thanks so much for inviting me, Jeremy. And it's good to see you again, even if just virtually. So good afternoon, everyone. As Jeremy mentioned, I'm an assistant professor of infectious disease at UNC. And as an academic person, I wear many hats. And one of my hats is actually to be an antimicrobial stewardship attending on the Carolina Antimicrobial Stewardship Program for UNC hospitals. And so today I thought I'd give an overview of antimicrobial stewardship and a related concept, diagnostic stewardship, which I'm sure is something that many of you are already familiar with, but mainly to give as a review, and then talk about some resources and also some of my favorite stewardship interventions that could be incorporated into your facility stewardship activities or your own practice or things that you model for our other non-ID colleagues. So hopefully this will be a good kind of review, get you thinking about stewardship and diagnostic stewardship, antimicrobial and diagnostic stewardship topics. So why do we care? Obviously, I think this is, something that we all know very well. Antimicrobial resistance is a significant and growing problem. And there was this recent review in The Lancet that tried to estimate the global mortality associated with antimicrobial resistance. And they looked at it in two different ways. So one was deaths attributable to AMR, and they considered a counterfactual where infections with resistant pathogens were replaced with susceptible pathogens. And then they looked at deaths associated with AMR, considering an alternative where the drug-resistant infection did not occur at all. And by doing that, they estimated that there were 1.27 million deaths directly attributed to AMR and almost 5 million associated with AMR just in the year 2019 globally. And they noted that the highest rates were in green here, which is the different parts of sub-Saharan Africa, where they noted the highest rates of antimicrobial resistance, at least during this particular year. A sort of companion paper looked specifically at the WHO Africa region. And on the left, again, is mortality associated with AMR. And on the right is mortality attributable to AMR. And as you can see, there are high mortality rates in Central African Republic, Zimbabwe, Mozambique, in South Africa, between 40 and 70 deaths per 100,000 population associated with antimicrobial resistance just in 1 year. So certainly a very common and growing problem throughout the world. We live in a global world, as you all know. So what is happening in one region can quickly and easily spread to another region. And this was obviously devastatingly illustrated by the COVID-19 pandemic, but is also true of antibiotic-resistant pathogens as well, bacterial pathogens. So travel-related spread of AMR organisms has been documented for carbapenemase-producing Enterobacterales, for Streptococcus pneumoniae, for linezolid-resistant Enterococci. So basically, you can't just say, oh, that's a problem in another part of the world. It's not a problem for my part of the world. It's important that that we address this with a global perspective in order to stem the spread of antimicrobial resistance. So what are the main drivers of antimicrobial resistance? This is a study from The Lancet that looked at the mechanisms and drivers of antimicrobial resistance. And on the y-axis is the relative contribution of each of these factors listed up here. And on the x-axis is the strength of evidence that that factor is contributing to antimicrobial resistance. And what you can see is that the factors with the highest evidence and also the highest relative contribution are human and animal antimicrobial misuse or overuse. So this is the most important modifiable risk factor for preventing the spread of antimicrobial resistance. So that kind of provides a framework for why antimicrobial stewardship is important. And so what is antimicrobial stewardship? Basically, we know that existing antibiotics are a limited resource, not only because of the development of resistance, although that is making them less effective, but also because the development of new antibiotics is slow. And when new antibiotics are developed, it often takes a long time for them to reach parts of the world that may need them the most. So they are only usually available in high income countries first. There's not an equitable distribution immediately after their production. So, and even with that, the development of new antibiotics is rare. So antimicrobial stewardship is the effort to optimize antibiotic use, to maintain the antibiotics that we have and maximize their potential impact. And that means improving prescribing by clinicians and use by patients outside of the traditional kind of healthcare sector. Also minimizing misdiagnoses and delayed diagnoses, which would lead to underuse of antibiotics, and to assure that the right drug dose and duration are selected when it is determined that an antibiotic is needed. So in summary, basically using antibiotics only when they would confer a benefit to the patient. And this is one of the three pillars determined by the WHO to be important to an integrated approach to health systems strengthening. The other two are infection prevention and control, and then medicine and patient safety as well. So something that's recognized by national institute health organizations as a key component to the progress towards universal health coverage. There's lots of evidence to support that antimicrobial stewardship improves patient outcomes, it saves healthcare costs, and it minimizes the unintended consequences of antibiotics. And that is not just development of antimicrobial resistance, but also things like Clostridium difficile infection and adverse events. I think, at least in the US, there's a common conception that oral antibiotics are benign and don't have side effects. But a study looking at emergency department visits for adverse drug events among children found that almost half were attributed to antibiotics. So side effects with antibiotics are common. These are not necessarily benign drugs. So the main goal, as I said, of antimicrobial stewardship is to maximize the benefit of these amazing tools. They've saved millions of lives while minimizing any collateral harm. And I want to just highlight that the WHO has some really excellent resources for antimicrobial stewardship, basically how to assess the existing activities at your institution or facility and how to implement others and integrate them into the clinical care and also the public health surveillance that's already being done at the institutions. The CDC also has some great resources as well. The CDC Core Elements of Antibiotic Stewardship is what their kind of website is called. And they recognize that there's not a one-size-fits-all approach for every type of healthcare institution. So they have it broken down by setting: hospital, outpatient, nursing homes, small and critical care access hospitals, and then also resource-limited settings as well. So lots of great resources already out there to kind of help on a big picture level implementing antimicrobial stewardship where you work. So relatedly, there's this concept of diagnostic stewardship, which is a little bit of a newer concept than antimicrobial stewardship. And basically, they go hand in hand. Diagnostic stewardship ensures that patients get the right test at the right time, as opposed to thinking about the right drug at the right time. And Morgan et al. In this JAMA article defined it as modifying the process of ordering, performing, and reporting diagnostic tests to improve the treatment of infections and other conditions. And he identified 4 different kind of points along the clinical pathway where diagnostic stewardship can come into play. So at the time a test is ordered, you want to order the test only if the clinical presentation is consistent with an infectious etiology. So this is, not getting blood cultures in the ED if just, because a patient has a high heart rate and doesn't have any other signs of infection or something like that, or not sending a urinalysis when a patient does not have any symptoms of a urinary tract infection. And then another pre-analytic kind of point where diagnostic stewardship can come in is the sample collection. So for instance, not drawing blood cultures off of a peripheral IV, which increases the risk of contamination. Something like that would be a diagnostic stewardship sort of concept at that point in the clinical pathway. And then there's the actual processing that the laboratory does, making sure to minimize colonization. And then finally, how the results are reported to providers. So one thing that is done by our microbiology lab using our electronic medical record is they hide the results of antimicrobial susceptibility testing for broader antibiotics, broader spectrum antibiotics, if there is a more narrow spectrum that a bacteria is susceptible to. So for instance, if an E. coli is ceftriaxone susceptible, they will hide the carbapenem susceptibility testing. So basically reporting results in a way that guides appropriate practice. Another way of thinking about diagnostic stewardship in a little bit more of a detailed pathway, this is from a WHO document on diagnostic stewardship, which is very helpful and interesting as well, if you're interested in learning more. And basically, they break down the interaction between the clinician and the laboratory into all of the steps. So that a patient presents to the healthcare facility, and then kind of the pre-analytic point that Morgan outlined in his article is where the clinician makes a diagnosis and the clinical staff collects the specimen. Those are opportunities for diagnostic stewardship like we discussed. And then next, the clinician starts an empiric treatment, they send the specimen to the laboratory, and then this is where the analytic point comes in, how the laboratory receives and processes the specimen, and then post-analytic, how they report the results that the clinician then interprets and makes adjustments into the patient's treatment. So with that introduction of antimicrobial and diagnostic stewardship, just kind of recentering us to these things, I'd like to share some examples of general stewardship interventions that can be either implemented in your practice or at your institution that we've done at UNC that have shown benefit and I think hopefully are of interest to you as well. So for this, I'd like to think in a little bit of a different framework of the clinical decision-making process. So it can also be divided into the steps that happen at the time of or before prescription of an initial antibiotic and the interventions that occur after a prescription of an antibiotic. So at that pre-prescription phase, one key stewardship strategy, which all of you obviously as ID providers know, is that when safely possible, it's important to collect cultures prior to starting antibiotics. This can, affect culture sensitivity. We all know that very well. Also, the appropriate culturing the appropriate culturing technique is very important as well. So at UNC, we had a campaign in collaboration with our surgical services to improve OR cultures. So we were having an issue where infection was suspected intra-op and cultures were not being collected before antibiotics were started, or not being collected at all. And then also that there were a lot of swabs being sent as opposed to the actual purulence or infected tissue. And so we had a campaign called Send the Blob, Not the Swab, and made a video with microbiology and the stewardship group, and then the head of surgical services at UNC to basically inform or provide information to our surgical colleagues about how it improves recovery of pathogens if you're not swabbing and allows for direct stains. So basically the advantage to doing cultures appropriately, and then also sending them if infection is suspected. So things that may sound kind of basic to us as ID providers, but may not be common knowledge to others and can greatly improve both your antibiotic and diagnostic stewardship at the pre-prescription phase. And then at the time of initial prescription, there are lots of cool resources to kind of help inform empiric treatments. So I think the local antibiogram is a really great way of considering your empiric antimicrobial treatment. And I'm sure all of your institutions have something similar. It allows you to think about the source, the most likely pathogens, patient-specific factors, like are they in the hospital? Is this a community-acquired pathogen, which may have a different susceptibility pattern? And this is what our antibiogram looks like at UNC for urinary isolates in the community. And I realize this is very small and hard to read, but just to give you an idea, and one of our current stewardship interventions is to start looking at creating an interactive dashboard as opposed to just having a static PDF that is updated once a year, but something that can be updated more frequently, that providers can access easily and kind of use drop-down menus to say, oh, this is a urine isolate. I am, in the outpatient setting, in the ED, what are the common pathogens and their susceptibility patterns? So for instance, for us with E. coli, that's the most common urinary tract isolate that our lab has seen. And we have about 20 to 25% resistance to fluoroquinolones. So probably not the best empiric choice for E. coli pathogen or E. coli urinary tract infections in our setting. And this obviously varies from place to place. The WHO has another great resource. I feel like I'm talking a lot about the WHO, but turns out they have a lot of great resources for these types of things. So they've created this AWARE classification, which stands for Access, Watch, and Reserve, and basically have assigned antibiotics into each of these three groups, with the green area being the best kind of first choices for common infectious syndromes and ones that countries and facilities should try and maximize access to. Whereas the reserve group is the broad spectrum antibiotics that are just last resort options for a patient who has a known MDRO. And they have an actual antibiotic book that has concise and evidence-based guidelines on the choice of antibiotic dose, route, and duration of treatment for more than 30 of the most common clinical infections in children and adults. So this is kind of a good place that we can refer people to when they're trying to determine their best empiric treatment at the time of prescription, and to practice stewardship at the time of prescription. And then thinking about the second half of that framework, post-prescription, it's important to reassess the antibiotic regimen on a daily basis to make sure that it's still appropriate for the patient and that we haven't gotten any other information that may change our treatment strategy. So these are called antibiotic timeouts, and they are a core element of hospital ASP per the CDC. And basically they address the third and fourth moment of antibiotic decision-making, which is a kind of this 4 moments of antibiotic decision-making is another kind of framework of thinking about antibiotic use. But you basically point 3 and point 4, or moment 3 and moment 4, are you have a patient who's on antibiotics. Now, can I stop the antibiotics? Do they still need them? Can they be de-escalated? Do I have new information that informs the choice of drug? Has dosing been optimized for the organ system that I'm trying to treat? And is it appropriate to convert from an IV to an oral antibiotic? So basically thinking about de-escalation if possible, or discontinuation if appropriate. And it's also important, a key element of this kind of antibiotic timeout is also thinking about duration. And I think this is something that is sometimes overlooked in terms of stewardship interventions. In place of, we are good about thinking about de-escalation and the scope of our antibiotic, but duration matters too. And there's kind of increasing evidence that even 1 day of antibiotics can disrupt or affect the microbiome and lead to pressure for development of antimicrobial resistance. And similarly, there's growing evidence that the duration of antibiotics needed to be effective for treating many common infectious conditions is shorter than previously known. And this, on the right, this figure I took from Brad Spellberg at UCLA. He's very active on social media, a big proponent of the evidence for shorter durations and also transitions from IV to oral. And he basically collates on his website all of the randomized controlled trials that support these practices. So it's a great place to start if you're wondering if a particular condition has evidence for a shorter duration. And basically in all of these things listed here, a short duration of treatment has been shown to be non-inferior to a longer duration of treatment. There are some exceptions. Acute otitis media in kids, 5 days was inferior to 10 in one randomized control trial for kids under 2. So, certainly it's not true for every condition, but for the vast majority of common infections, the more we learn, the more we realize that shorter durations are appropriate and just as effective. So something to keep in mind. This is what timeouts looked like at UNC. So basically, the team, we have a pharmacist who's embedded in each of the medical teams. And the pharmacist would identify patients who had been on antibiotics for at least 36 hours. And then on rounds, they'd call an antibiotic timeout and complete this checklist, which was a smart phrase or a dot phrase that we could put into the electronic medical record. And the questions would be like, what does this patient have? What antibiotics is the person on? What culture results do we have? Are the antibiotics still indicated? And can we do anything to change or optimize our antibiotic treatment? And then the pharmacist records all of these answers. It gets saved in the chart, and it allowed us to track it over time. So this is, a confusing or I guess a slide with very small font, but this is basically to show you the dashboard that was generated from those smart phrases about antibiotic timeout since this program started in 2018. And basically, our goal was to have 80% of appropriate patients receive a timeout in the timely manner, and almost all of the services achieved that. And then as of February 2024, a quarter of the completed timeouts actually led to changes in antibiotic regimen. So it was about 25%. So certainly having an impact on antibiotic use on an individual level as well. This is not something that has to be done as part of a huge formal program. It's also something that can be done informally. It's a practice we can model for our non-ID colleagues to ensure that we're using our antibiotics in an intentional way. Another similar type of intervention that addresses that kind of post-prescription thought process is called Handshake stewardship. So this is something that we're just trying out at UNC. We're doing a kind of pre-post crossover study to look at its impact. But in this framework, a stewardship physician and pharmacist meets with a primary team a couple of times a week, and they discuss all patients receiving IV or oral antibiotics. And this was really championed by a group at the University of Colorado who did this in their peds departments, and they noted a significant decline in antimicrobial use and Clostridioides difficile infection with the implementation of this handshake stewardship program. So it is resource intensive. It requires having a dedicated stewardship physician and or pharmacist who can meet with teams on a regular basis, but it leads to a decrease in antimicrobial use, and also just helps with general education. Like over time, these studies have found that there's less and less to intervene upon or to discuss because the primary teams are learning from the interactions with the stewardship providers. So it can certainly have a sustainable impact even after the high intensity intervention phase. So shifting gears, I'd now like to talk about some of my favorite disease-specific opportunities for stewardship. And I'm sure many of you are aware of these, but I'm hoping that this will help you think about them in a structured way, and kind of remind you of them and think about how we can incorporate them into our practice and model them for other non-ID providers. So one of the common reasons that, at least as ID consultants in the US, we get consulted is for gram-negative rod bacteremia, particularly those with Enterobacterales. And there's actually growing evidence that in patients who are clinically improved and who have had appropriate source control, so this is a group of patients that was sick and is getting better, consider early transition from IV to oral therapy to complete the treatment of their bacteremia. So one of the main retrospective studies of this was a multi-center cohort study that included one-to-one propensity score matching of 5,000 patients hospitalized with monomicrobial Enterobacterales bloodstream infection at 3 different academic centers in the US. And their primary outcomes were 30-day mortality and recurrence of bacteremia, and they noted no difference between the propensity matched groups. Important to note that 70% of the oral group received fluoroquinolones, but 16.5% received oral beta-lactam, so still a significant proportion, and they did not notice any difference in their outcomes based on the oral drug that was chosen. Since then, there's also been a randomized control trial that looked at this and confirmed the findings seen in retrospective studies. So this was a trial done in Bahrain, Kuwait, Qatar, and Turkey, and they enrolled patients who had completed 3 to 5 days of microbiologically active IV therapy, were afebrile and hemodynamically stable for 48 hours, and had the absence of an uncontrolled source of infection. So a carefully selected patient population, for sure. But when they were randomized to either continue IV therapy for completion of the course or switch to PO, their primary endpoint was treatment failure, which was defined as a composite outcome of death, need for additional antibiotic therapy, microbiological relapse, or infection-related readmission within 90 days. And they found no difference between the 2 groups, the oral group or the continued IV therapy group. both for their intention to treat and modified intention to treat analyses. And then when they broke down the individual components of the primary endpoint, they also did not see any differences there. So basically in this, carefully selected patient population of people who are improving on IV therapy, reasonable to consider transition to PO to finish the course. And then as we've discussed previously, duration is important. There's also evidence that a shorter duration of treatment for these patients who are clinically improved may be appropriate as well. So this was a randomized control trial that compared 7 days to 14 days of antibiotic therapy for uncomplicated gram-negative bacteremia. So they randomized people once they got to 7 days, either stop treatment or continue for an additional 14 days. So, to be in the study, you had to have survived to 7 days. So, that probably introduces a certain amount of selection bias. But what was cool about this study is that they included elderly patients and also immunocompromised patients. So people with solid organ transplants, people who had a history of malignancy. So groups of patients that are often included or excluded from these types of studies. So that was kind of a unique aspect of this randomized control trial. And what they found, their primary outcome was 90 days. At 90 days was a composite of all-cause mortality, relapse or distant complications like suppurative complications, or readmission or extended hospitalization of longer than 14 days. So for that composite outcome, the 7 days of therapy group was non-inferior to the 14-day therapy group. And that was regardless of what subgroup they looked at. So they looked at UTI and non-UTI as the source of bacteremia. They looked at whether or not the empirical coverage actually treated the pathogen that eventually grew. And they looked at both drug-resistant and non-drug resistant pathogens and didn't find any difference. So determined that 7 days was not inferior. So in summary, in a patient who has an Enterobacterales bacteremia, they've been on a couple of days of IV therapy, they're improving, they're hemodynamically stable and afebrile, they don't have an uncontrolled source of infection, those patients can probably safely get 7 days of therapy, and the course can be finished with oral antibiotics. So definitely different, I think, than the practice, at least that I learned in fellowship. Another one of my favorite stewardship interventions is the MRSA nasal screening for pneumonia. So the nasal screening for MRSA has a high negative predictive value for ruling out MRSA pneumonia. This was a meta-analysis that was done including both culture and PCR-based methods for MRSA screening. And basically what they found is that in the 22 studies, when they did the meta-analysis, a negative MRSA nasal screen had a negative predictive value of 95 and higher %, depending on what subgroup was looked at, for ruling out MRSA pneumonia. So this is something that we are, was just, I guess, probably 1 to 2 years ago, brought up in our laboratory. Previously, we had culture-based, but now we have PCR-based testing, which comes back in about 24 hours. And so we are trying to educate providers about its existence to kind of decrease our anti-MRSA coverage use, for instance, vancomycin or linezolid. One of the things we've kind of noticed as a collateral effect is that people are using it for non-pneumonia conditions, such as skin and soft tissue infections. And so there's more education to be done regarding the fact that there's no evidence to support the use of this test for non-pneumonia indications that I'm aware of. Next, another favorite of mine is penicillin allergy delabeling. I find it very satisfying to remove penicillin allergy from people's charts when appropriate. So I don't know how much of penicillin allergy is an issue in the settings where you all work. So I'm interested to hear about that. But at least in the US, approximately 10% of patients report having an allergic reaction to penicillin in the past. However, most of these patients did not have a true IgE-mediated reaction, or if they did, about 80% of people end up outgrowing that IgE-mediated penicillin allergy over time. And so less than 1% of the population is truly allergic to penicillins. Yet having a penicillin allergy on your chart leads to overuse of broad-spectrum antibiotics. It leads to increased Clostridium difficile infection, And it leads to increased risk of antimicrobial resistance and use of suboptimal antibiotic therapy, for instance, like vancomycin for MSSA, bacteremia, or endocarditis. So identifying individuals who have a low risk allergy history, who can be delabeled, challenged orally, or referred for penicillin allergy testing is an important stewardship intervention. And this is one tool that can be used to risk stratify folks who have a reported penicillin allergy. It's called the PenFast tool. And basically it looks at the duration of time since the reaction, whether or not anaphylaxis or angioedema was present, if there was a severe cutaneous reaction, which is getting at more of a type 3 hypersensitivity, and then if treatment was required for the reaction. And basically people who have a score of 2 or less are low risk for having a true penicillin allergy. At UNC, we use a little bit more of a complicated risk stratification chart, but basically divide it into 4 groups. So based on history, we can sometimes tell that the patient is not allergic. So maybe they say they have an allergy to amoxicillin, but that they got Zosyn at their last hospitalization, or Piptazo. So we can say that, they are tolerating penicillin allergies and just delabel them without any further testing or intervention. And then kind of these other categories are all associated with particular recommendations with the goal of doing oral amoxicillin challenges or referring to allergy for penicillin allergy testing to then delabel the patient if there's no longer a reaction. And we're trying to kind of increase the use of these screenings in the inpatient setting and actually doing some penicillin allergy challenges or delabeling while the patient is hospitalized and they're a captive audience. And so that is one of our current initiatives. As a side note, I want to highlight this paper, and this figure is obviously very small, and I'm put it here not to intend for you to read it, but basically this paper has a really great sort of graph here that looks at structural similarities in the R1 and R2 side chains of beta-lactam drugs. And so the ones that have identical R1 side chains where there would be concern about cross-reactivity are highlighted in red, and the R2 chains are in yellow. And so basically, for instance, cefazolin is a commonly used antibiotic in our setting, and it basically has cross-reactivity with no other beta-lactam drugs except ceftazole, which is not something that's available in the US. So generally, cefazolin is safe to use in the context of a reported beta-lactam allergy. So I refer to this chart all the time, especially after hours when I don't have access to an ID pharmacist or a allergy and immunology fellow. It's very useful. A couple quick ones just to wrap up with. So this is a diagnostic stewardship intervention that I'm sure you're aware of. The idea of only testing for C. diff if the pretest probability of infection is high. So at UNC, we've defined that as at least 3 loose watery stools in 24 hours, not on laxatives for the last 48 hours, no previous positive test in the last 14 days, and no previous negative test in the last 7 days unless there's new symptoms. And so now we have a what's called a best practice advisory. So when someone tries to place the order in the electronic medical record, something pops up where they have to answer questions about these characteristics. And if they answer in a way that indicates they want to order a non-guideline based test, then it stops them from ordering it, prevents them from ordering it, and requires them to call the on-call antimicrobial stewardship provider to request basically approval to order the test. And this was done to reduce our C. diff rates in the hospital, thinking that some of them were over testing, basically detecting colonization with C. diff instead of true infection. And I just put this here. This is our C. diff diagnostic algorithm. We start with an immunoassay, and then it reflexes to NAT testing if negative or indeterminate. That's kind of our testing algorithm in the lab. And systematic reviews have shown that electronic alerts for diagnostic stewardship regarding C. diff diagnosis can lead to reductions in testing and the proportion of inappropriate tests. Although there is concern for this idea of alert fatigue, which we've noticed at UNC too, where people, just try and click through things to get through the order, and they'll put in their own name instead of the stewardship provider to get it to allow them to order it. So there are kind of collateral effects of every type of intervention that we attempt to put forth for stewardship. And then finally, in the context of urinary tract infection, we all know it's very important not to treat asymptomatic bacteriuria, except in certain very specific situations. And this is recommended by multiple guidelines from the IDSA and the ABIM Choosing Wisely campaign. But it's still a practice that we see commonly, and it's difficult not to treat when you have a positive culture. So really, this is a diagnostic stewardship intervention of not sending a urinalysis and culture unless the person has clear symptoms of a urinary tract infection. So this is an infographic that we developed to educate providers, both in the outpatient and inpatient setting, to prevent over-treatment of asymptomatic bacteriuria. So this is another thing that we can educate non-ID providers about very easily, and hopefully improve antimicrobial stewardship for this particular condition. So I'll leave you with kind of the summary of antimicrobial stewardship that I find very useful. And if you remember anything from this talk, remember the 6 Ds to incorporate into your medical practice when treating an infection, or to when you're teaching someone else about antimicrobial stewardship. The first D is diagnosis. Do we have a clear idea of what we're treating? Have we sent the appropriate diagnostic tests in the appropriate way? Next, do we have source control of the infection? And based on our diagnostic information, or the diagnostic information that is going to come, do we have the correct drug? Are we using the right dose to get into the organ system that we're concerned about, or the organ system that's effective? Are we using the shortest effective duration? And can we narrow the spectrum in any way to target our infection? So those are kind of the core components of antimicrobial stewardship. And if you think about the 6 Ds, we can all be stewards. So I am part of the Carolina Antimicrobial Stewardship Program, and they, of course, support me in all of the activities that I talked about. Certainly, most of them are not my work, so I just want to highlight that this is very much a team effort. And we have a website if you're interested in learning more about some of the resources and programs that we have at UNC. It's there on the bottom. So I will happily answer any questions at this point. Thank you for everyone's attention.
Thank you so much. That's a really, really, really amazing overview, and very practical and useful, and lots of resources. I think "send the blob, not the swab" is going to be soon going to be the top phrase in infectious disease societies in South Africa. So well done on that. That's already whipping around WhatsApp as it's going. So congratulations to whoever came up. Yeah, I mean,
it's all Melissa Miller. I can't take credit for that.
Yeah, she could pull it off. The switch from IV to oral earlier than has been shown in the past, I think is really, really helpful, especially in places like here where we don't have a big OPAT program, the outpatient antibiotic program. It's really, functionally the duration of intravenous therapy determined the hospital stay. So those two things were kind of tightly linked. So it's been fantastic to see those kind of changes, and I think there's a lot of enthusiasm, probably more enthusiasm than in many countries around here, that is, really to try and grab onto this sort of new evidence and push it forward, even if there's, minor quibbles still here and there. But, did you study it in the following samples? People are quite happy to try, because it's the alternative is not benign, staying in hospital. Did you find, I'm always interested by the sort of implementation of this in countries where you do have well-functioning OPAT service. Did you find a lot of pushback initially, or were providers very happy with this idea? Or, what were the kind of, what is your experience with pushing people to switch to oral earlier?
So I think in the context of gram-negative rod bacteremia, I feel like it's actually been adopted pretty easily, especially by kind of our hospitalist providers. It's been something that they ask about and implement pretty frequently. I think where we've struggled particularly among ID providers, just because for so long we've used long IV to oral courses, is in things like, or I'm sorry, long IV courses, is in things like osteomyelitis and endocarditis, those infections that require weeks of treatment. People have just been doing it the same way for so long, and the assumption is that way is therefore better. Even though there's very little evidence to support that practice from, decades ago. So I think, there has been kind of more discomfort and more, or at least I shouldn't say discomfort, but a slower adoption of transitioning patients with osteomyelitis or endocarditis from IV to oral, even though there's, some growing evidence that it's safe to do so. So that I see more kind of pushback there. We are lucky to have a relatively strong OPAT program, but it's really, not without limitations. And, some people are just not good candidates for OPAT. It's not necessarily an easy thing to always do at home. And so we certainly have patients who end up staying in the hospital for their full 6 weeks of therapy, or they go to a skilled nursing facility and they get a bed sore, so I think there's still a lot of room as the evidence for these kind of practices grows to improve stewardship in those areas.
Mm.
And I realized that when I was presenting this may be something that everyone does routinely in South Africa already, so it's not news. So I apologize if that's the case, if this is something that's routine practice already.
No, look, I don't think it's routine. I think it varies a lot by place to place, but I think more and more people are doing it, and I think encouraged by the fact that the alternative is really just inpatient admission for everyone. So I think certainly we're much more likely to grab hold of any evidence to suggest we could switch to oral than if you have other options. I'm just looking through the chat for some of the questions. Lauren's asking about how big your team is. Lauren, I'm presuming meaning for the stewardship team, the antimicrobial stewardship, and who's a part of it. So what's the stewardship team look like at UNC?
So there are about 12 core members of our team. And I should say that UNC's stewardship program is newer than some of the other ones. It's been around, probably 10, maybe 15 years. And there are certain institutions that have much longer, well-established stewardship programs. But our team is led by an ID pharmacist. And then there are supporting ID attendings. So the kind of medical director of the stewardship program is Nicholas Mavroyorgos, who's one of the general ID providers in our department. And then we have, I should say this is the core stewardship team. So it's ID pharmacists on both the peds and adult side, and then ID attendings who serve as kind of the backup, doing prospective audit and feedback. We help lead research interventions, that type of thing. And then we have a broader stewardship group that meets on a monthly basis, and that includes representation from nursing, from hospital administration, from our surgical colleagues. There's also hospitalist representation on that committee. So that's a much more broader committee, but kind of the core group is 12 people, and we sort of determine kind of our key strategies for the year. So we have, four or five things that we do all the time: the prospective audit and feedback, the management of restricted drugs, that type of thing. And then we have basically focuses or strategies that we do each year to kind of target particular issues at the institution. Does that answer your question?
That's helpful. I see a couple of questions about the use of biomarkers. I think CRPs, procalcitonin, and that sort of thing in terms of stewardship in a hospital setting.
Yes. So I would say that this is a practice that is a lot more common in Europe than it is in the US, the use of biomarkers for de-escalation of antibiotics. So at UNC, the only context in which we use procalcitonin is actually in the pediatric febrile neonate patient population, because both CRP and procalcitonin have been incorporated into the guidelines for management of a febrile neonate between 28 and 60 days old. So in that context, we use it, but our institution has not really adopted procalcitonin at all, even in like settings like the ICU for de-escalating antibiotics, things like that. Folks have felt that the evidence wasn't quite as strong. In terms of CRP, oftentimes people use it to kind of track over time patients who are being treated for osteomyelitis, things like that. But in terms of decision-making for antibiotics, yes or no, it's not generally used in our setting. But I know that in the UK and in other parts of Europe, it's very common to use a CRP. And actually, one of my areas of research is implementing CRP tests in rural Uganda, so with the village health workers, to try and decrease inappropriate or unnecessary antibiotic use among children presenting with febrile respiratory illness. So I do think that they are very powerful tools. I think in the US setting, we don't use them very often, or at least at UNC. I think they're more commonly used at community hospitals. But I do think that they have a very important role to play in stewardship, and that kind of disregarding them, kind of, what's that expression? Don't let perfect be the enemy of the good type of thing. And so that they can be very powerful tools for stewardship.
Yeah. It's used quite a lot here, but I much prefer the US approach to it. I think that you're right, that, used correctly, I think that, definitely got a role to play. The danger is here it's often used as a kind of crutch where, if the PCT or CRP goes up, well, it's an infection. And if it comes, and if it comes down, then you can stop it. Right. As you said, it's not quite as clear as that, unfortunately, despite, and obviously some trials look better than others, but it's sort of when you pile them together. And
it may be that a certain patient population that has, the people who are very high risk for infection, there's no reason to do testing there. If they're very low risk for infection, you don't need to use it. I think probably there's a way to target a patient population where it's most appropriate and can be the most useful.
And there's a question about how do you encourage de-escalation of therapy from broad spectrum to narrow spectrum antibiotics?
Me personally, or
the program from a stewardship perspective?
The program. Yeah. So one of the things that we do is we, on a daily basis, review carbapenem use. So basically all the patients at UNC Medical Center who are on carbapenems, we can create a list in the electronic medical record. We actually look at cefepime, piptazo, and carbapenems, but really focus on carbapenems, and we look at patients who have been on it for at least 24 to 48 hours. And so there's a lot of prospective audit and feedback that we do where we talk to primary teams and kind of say like, hey, I noticed you chose meropenem for this particular patient. I don't see that they have a history of a multi-drug resistant organism, kind of what is the thought process? And it's really a conversation and kind of sharing evidence of situations where de-escalation could be appropriate. It is challenging though. And I think, UNC is a place that maybe on the spectrum of antibiotic use culture, we're on the side of sort of physician independence and we don't, restrict carbapenem use in the hospital. We only restrict kind of the new beta-lactam, beta-lactamase inhibitors and cefiderocol, like that level of drug. But we're not, people can use carbapenems without approval from an ID or a stewardship physician at our institution. And so it's, a lot of conversations and during the pandemic, that was all virtual. And now we're starting to try and do more in-person work, like with this Handshake stewardship project. For instance, to kind of just like make stewardship more visible and keep it on people's minds and hope that that has kind of downstream effects in terms of what empiric treatment is started.
Okay, great. I think those are the questions. So thank you very, very, very much. Hugely appreciative of your time. I know it's still morning there, and I can tell the audience I did manage to tell Emily this was on Thursday and only corrected her last Friday. So she's pulled this together with a shorter time period than she thought she had. So thank you very, very, very much, Emily. It's so nice to see you again. And thank you for a fantastic talk. Really, really, really useful. My phone is buzzing from all the congratulations and appreciation from some of the audience. If only there was a clap sound that would come on Zoom, but I'm sure the next time. Yeah. Cool.
Well, thank you very much for the opportunity, and I hope you all have a very good afternoon.